Good afternoon, everyone, and welcome to the COVID-19 2.0 Health Literacy Echo for Medical Providers, brought to you by Health Confianza, a collaboration between the UT Health San Antonio and the San Antonio Metropolitan Health District. Thank you very much for making this time one of your priorities in joining our session today. I would like to mention that we are recording this session so we can share it later, but your names are not listed in the recording. My name is Raquel Romero. I am so glad to see you, and I hope you and your family doing well. I'm a physician by training, and I'm going to be the facilitator for the session today. We have a lot of information to cover, but before we begin, I would like to ask our ECHO IT person to provide some directions for us.
Hello, everyone. Please stay muted. Unless you're speaking, you can use *6 on your phone if you've called in, or the microphone icon on the bottom left of your screen if you've joined on the computer. You can also communicate with the chat feature by clicking on the speech bubble icon on navigation bar at the bottom of your window. If you're having issues with your connection, you can privately chat ECHO IT.
Thank you very much. So if you have some issues with the connection, you can send a private message to the ECHO IT. You can also add your comments in the chat box, and I encourage you and I invite you to add your comments, your perspectives, and your questions in the chat box. We would like to hear from you, and we will try to address them and follow up them during the session today. But if also you can reach out to us after this session by email. And we promote interaction in our sessions, and we would like to see everyone's faces. If you are able and comfortable, I invite you to join us by video, especially in the discussion part of the session. And please remember that no personal health information is allowed within discussing cases and scenarios. I would like to mention that those sessions are open to everyone. Once you register for one session, you automatically will be registered for the complete series. Please mark your calendar. I would like to go ahead and do the introductions, and we have a large group, so help us with our attendance records. I would like to ask if you please add you in the chat box, add your name, your title, the organization, the institution that you represent. We would like to hear from you. We would like to keep a contact with you. With that, and before continue with our session, I would like to say thanks to the Health Confianza. It's a county-wide collaboration to improve access to the COVID-19 health information and services in Bejar County. I would like to then go ahead and do the introduction for our ECHO team, and I would like to start with Dr. Bergen, leader specialist and moderator.
Hello, everyone. Welcome. My name is Dr. Ruth Berggren. I'm a professor of medicine and an infectious disease specialist, and along with my colleague, Dr. Romero, I will be helping to moderate this session. Thank you for being with us.
Thank you so much, Dr. Bergen. We have our didactic speaker today, Monica Verduzco-Gutierrez.
Hi, Dr. Gutierrez from Physical Medicine and Rehabilitation.
Thank you very much. Dr. Avery, this is for a case presenter.
Hello, my name is Richelle Avery. I'm a primary care physician. I work at UT Health Verde Hills location.
Thank you very much for presenting the case. And also Dr. Shi presenting a case today.
Hi, my name's Yun Shi. I'm a family medicine doctor practicing at the Robert B. Green Clinic.
Thank you very much. Our panelists for today, we have Dr. Sanka.
Hi, I'm Ratna Sanka. I'm a neurology department. I'm with the neurology department at the UT Health San Antonio. Thank you for having me.
Thank you very much for joining our session. And Dr. Pilarisetti, panelist for our session today. You are muted, Dr. Pilarisetti.
Yes. Hello, everyone. I'm Dr. Jayashree Pilarisetti. I'm an associate professor here at UT Health San Antonio. And I'm happy to join you all here.
And importantly, you're a cardiologist, right?
Yes. Yes, I'm a cardiologist, electrophysiologist. So I do see patients with POTS and inappropriate sinus tachycardia and a lot of post-COVID patients.
Wonderful. Thank you.
Wonderful. Thank you so much for joining our session today and be part of our panelist. I would like to go ahead, we have some announcements and updates, and I would like to start by saying that these sessions are possible because of you, because your interest, your participation, and your support. A quick reminder, towards the end of the session, our team will send you a link for an evaluation. Would you please take a minute and complete that evaluation? Your feedback is so important for us. We're also inviting clinics to participate in these echo sessions. If you're in a clinic, provider, organization that may be interested in participating in these sessions, please reach out to us. We would like to send the information. ECHO stands for Extension for Community Health Outcomes. This is a model of learning opportunity and telementorship. And the goal is to bring the knowledge when it's needed, where it's needed, to build a community capacity for delivering of care. Our components are the brief didactics, case discussion, and dynamic conversation. A case discussion is an important component of the ECHO model. We invite you to submit a clinical or non-clinical case. And for those that are already presenting a case, would you please consider a present a follow-up? We would like to hear from your experience. ECHO IT will share instructions for the case submission in the chat. Please check out our website to learn more about the ECHO model and ongoing ECHO programs. For this series, we offer in the CME, the CNE, and ethics continuing medical education, and to obtain those credits, and you please follow up the instructions in the chat. The activity code for today is 100-92315. Finally, I would like to mention that ECHO is all teach online environment, so we encourage you to share your experience, questions, and insights in our conversation today. With no more from my end, I would like to get started with our didactics. Dr. Verduzco-Gutierrez, this is your space. When you're ready, please take it away.
There you go. Unmuted myself. I'm going to give you an update about where we are with long COVID since I talked to you last. Lots of things change, lots of data comes out all the time. So I'm going to kind of talk about what we know and what we're going towards, and what are some of the treatments that we know that we can begin to offer now and begin to think about when it comes to patients with long COVID, and where research trials are going. So just kind of, this isn't perfect, but it's a nice little nuance to a PASC, or post-acute sequela of SARS-CoV-2 diagnoses. So we almost have, there's two pathways. One is persistent symptoms with an obvious medical cause. And that's when the patients will have something, they get a CT scan and they have pulmonary fibrosis, they have abnormal LFTs or PFTs, or for someone with acute kidney injury or myocarditis, pericarditis, there's ones where we can see some end organ damage on standard tests that we have. And then there's a group of people that we don't, they have a persistent symptoms that are ongoing that, are part of long COVID that may be driven by autoimmunity. They may have dysautonomia or autonomic dysfunction or just the fatigue, but a lot of their tests are coming back normal. That still falls under PASC and long COVID. And we do have to make sure that we rule out the ones with the obvious medical causes, and that we cannot tell people it's not real, even if they don't have an obvious cause that we know so far as part of what we can test. So this is a nice little picture that shows, what are some of the pathogenesis right now that we think may be happening in regards to long COVID. And one of those is SARS-CoV-2 viral persistence. So there is, viral antigen or viral antigens that persist, whether there's been studies, it's shown to be in the GI tract, in the fat, in the brain, and that's driving an autoimmune response and driving inflammation and persistent biomarkers. Some patients, it may be ESR-CRP, but some of those are not. Sometimes it's things we can't check that aren't available in typical labs, but only in research, like interferons, IL-6, IL-10, IL-13, those different types of cytokines and chemokines. yet that are high in patients, but we don't know because we can't test them with what we have. There's definitely viral reactivation. So I do recommend sometimes if patients have a history of EBV for looking for EBV and seeing if it's reactivated, because that has been shown to go with long COVID. There's virus immune response that's occurring, autoimmunity. So in some patients, especially if they start having either rheumatological or neurological symptoms, look for, an immune disease, because that has been developing some of these patients. And then there is also the microthrombi and the endothelial dysfunction. And again, we don't have a good microthrombi test, though some patients are getting large deep venous thromboses or pulmonary embolisms. That's of course easy to find, but we don't have the test right now for the microthrombi, but these are driving PASC and long COVID. And this is a very, very nice picture that shows what's happening, because these are the symptoms that your patients have, and they come in and they're like, I have headaches, migraine, body aches, pain, fatigue, decreased endurance, nausea, vomiting, things that just a lot of symptoms. And while they may have had, you're going to be a good physician and you're going to just make sure, okay, well, their other testing seems to be normal. When I look at their heart and their echo's fine and their lungs fine and their CT chest is fine, and maybe they do not have the typical end organ damage, but these disparate symptoms are actually very, very interrelated, and it's more related to a disrupted immunity and inflammation and nervous system dysfunction. And, part of the treatment is time, is decreasing inflammation, is, breathing exercises, is some rehabilitation, and we'll go, and then just treating these as symptom management for these things individually. So, if they have a sleep disturbance, make sure they don't have obstructive sleep apnea, treating their sleep disturbance. If they're having migraines, treat their migraines very aggressively. If they're having pain, the same thing with those things. So again, I'm going to put in a plug. We have a multidisciplinary collaborative group that is 41 long COVID clinics around the country, and the American Academy of Physical Medicine and Rehabilitation has a collaborative, and it's there's specialists from all types of medical specialties that are part of this group and that are part of the collaborative in the clinics. And we have already at least 6 consensus guidance statements. This is the one on fatigue, and the fatigue one, and all of them, there's a cardiologic one, and Dr. Pillar said he helped that. We had a neurologic one that's about to come out. We have an autonomic dysfunction one. We have a cognitive deficit one, a breathing one. And so also Dr. Senka helped with the autonomic and the neurologic one, and myself being co-authors as well. So there are guideline statements that are out there in how to do the initial screening. And it will tell you, these are the assessment recommendations. And then what is the workup that should be done as well. And one thing I'm going to always stress is please learn about post-exertional malaise. That post-exertional malaise is actually one of the cardinal symptoms of myalgic encephalomyelitis, chronic fatigue syndrome, and also in some studies that up to 40% of patients with long COVID are meeting the criteria for ME/CFS, that actually their fatigue is meeting the criteria for, chronic fatigue syndrome. So please look for this post-exertional malaise or post-exertional symptom exacerbation. So that's going to be an exacerbation of their symptoms after doing some kind of activity that maybe seemed like a really simple activity that they could do before, but after the activity, they can be knocked out either with more fatigue or more of the symptoms they were having that may occur over the next day or two and can knock them out for a long period of time. So that's why in treating these patients for the fatigue, you screen for that. And then these patients can't do the traditional rehab. They actually have to do more of pacing themselves and slowing themselves down. I had one patient, he's going through aquatic therapy to help with his fatigue. And it's actually, he said, I can't do anything else at home. So I have to be able to determine, okay, well, maybe we do less of the aquatic therapy, so that way you can work on just pacing yourself for your activities that you have to do at home. This is, if you want to get the, take a snapshot and get a link to the guidance statements. There's even a pediatrics ones for those of you that may be seeing children, and it gives recommendations since, yes, long COVID happens in children as well. So what do we know for treatments? And I'm going to kind of tell you this is based on a research paper and things that we're knowing, are going on in long COVID. And these are the possible mechanisms and possible therapeutic strategies to start to think of. So we know that, the acute viral infection can cause in some people irreversible tissue damage. And so for that, we have to prevent, continue to encourage our patients to wear masks and get vaccines, giving giving them antivirals if they meet the criteria. I even kind of have a tendency to maybe be a little bit more generous with the antivirals, especially since if we think that viral antigen persistence is going to be driving long COVID in some patients. Post-acute vaccination, I'll talk a little bit more about that, where vaccination sometimes actually may be a treatment for long COVID, anti-inflammatories, and then rehabilitation, especially if they have a need for pulmonary rehabilitation or cardiac rehabilitation. And so, if a patient's hospitalized, still recommending that inpatient rehab helps for a person who's had ARDS and has been critically ill with COVID. And there is more studies just showing the benefits of comprehensive rehabilitation management for patients who are hospitalized with severe COVID-19 from across the world. And what about for outpatient COVID rehabilitation? Especially, there's been a lot of, especially with Omicron, a lot of autonomic dysfunction, and that there's actually progressive autonomic reconditioning and therapy that can be done. So that's like physical therapy actually that goes very, very slowly, all about retraining the autonomic nervous system. And patients start with even recumbent type exercises, because usually when they're orthostatic, when they're up, the standing gives them more symptoms. So a lot of the therapy starts even with simple laying down and moving their legs up. Breathing exercises, very, very important in these patients, as it helps increase their vagal tone, and again, avoiding post-exertional malaise. There's just a picture of a little machine that some patients can try to help with inhalation exercises. There's a living guideline now with the World Health Organization. So like I said, there's a lot of stuff that's out there, and the living guideline that was updated last month has a whole section on rehabilitation of adults with COVID-19. And it says, it should be multidisciplinary, it should be, continuing throughout their recovery, and it should be people-centered. We have to look for red flags for safe rehabilitation. So if they're having exertional desaturations or cardiac symptoms, please make sure that you're getting troponins, BMPs, EKGs, echoes, because even though a lot of them are having normal testing, you do not want to miss the ones that are having that may be one of those few percentage that actually have cardiac disease. So it's important to look for that, especially before sending them for physical exercise. Again, you have to assess for post-exertional symptom exacerbation and make sure those people are pacing themselves, because graded exercise therapy, the traditional physical therapy, does not work in those patients. They just crash and do worse. So you may be actually making it worse for them by just sending them to traditional physical therapy. Again, screening for orthostatic intolerance. The autonomic dysfunction, I cannot say that enough, is very, very common in long COVID. You can go a very long way by just having a patient do a stand test or a NASA lean test in clinic. It takes 10 minutes for them to do that. And then return to everyday activities and work, really, again, stressing energy conservation and a phased return to work program. The other thing it's very important to use validated measures when you're asking about fatigue, not just like, oh, are you tired, but actually doing like a fatigue severity scale or one of these health-related quality of life, DePaul symptom questionnaire, neuro quality of life scale. The PROMIS has a fatigue index as well, 10 simple questions, and they're validated. And this can sometimes make the difference between someone getting disability or being declined, and really figuring out how disabling someone's fatigue is. Please know and teach triggers for them, like is it physical or cognitive. Physical or cognitive exertion can be a trigger that makes them worse. Stress can make them worse. Dehydration, being hydrated is very, very important in these patients, especially the ones with autonomic dysfunction. The weather changes is a big thing I hear, and heat, and we're in hot San Antonio, but also like when, like this week when a front came in, patients feel really bad around that time. Consuming large meals, because then all the blood goes to your stomach and it's not going, peripherally or to your brain where they need it. Alcohol, some of these patients, they cannot tolerate it at one bit. And, I definitely don't recommend they're taking it during this time. And for people who menstruate during the premenstrual period, they can definitely have a trigger. And we want to support people for work accommodations when they can have them, knowing that they need time to recover. There's, pushing themselves too hard is going to be a trigger for a relapse and post-exertional malaise, and they really need reasonable reentry back to work. And there are some accommodations also that can be recommended for patients. So what is another therapeutic strategy? Persistent viral infection and ongoing tissue harm. I talked about that a little bit. They actually just opened for the RECOVER trial. Since we're a site here, it was announced yesterday, the first treatment trial they're going to do is with Paxlovid for patients who are living with long COVID, and they're going to be doing it regular dose, 15 days instead of 5 days. And this is going to be in persons with, again, long COVID who are part of the RECOVER trial, to see if Paxlovid is going to be, one of the treatments to see if that persistent viral infection and ongoing will help with long COVID symptoms. So there's other antivirals that as well. If patients meet the criteria for Evusheld, I'm recommending Evusheld for them to get it. There's an order, at least through our system, and then therapeutic vaccine. So, there's been studies showing that, observational studies, those who had PASC, who were vaccinated, some of, over half had improvement in their symptoms, some did not change, and some, maybe a few percentage deteriorated. So, it's something in these studies that we say, okay, I'm still recommending my patients to get the boosters and their treatments because it's been shown to be helpful. The other thing is, if one of the other mechanisms is inflammation, whether the direct from the virus or indirect from other viral reactivations or from dysbiosis. So these are some treatments that are being considered, anti-inflammatories, antihistamines, definitely for the, in the UK, one of their major trials is doing the antihistamine trials, especially if it looks like there could be any mast cell dysfunction. So if your patients talk about GI complaints, rashes, those types of things, then I will put my patients on a type of mast cell protocol with non-sedating antihistamines, both H1, H2, and sometimes add montelukast as well. Looking and treating viral reactivations if they have it, and then looking at the microbiome. So sometimes even starting with just, a prebiotic and a probiotic. For autoimmune treatments, since, some patients it's immune system mediated, these are some treatments that they are considering and doing for research for autoimmunity for this patient population. IVIG has been treated in some of our patients, and Dr. Senka can talk about that when they've developed actual autoimmune antibody that we can therefore get it approved for. I'll talk a little bit about low dose naltrexone. So naltrexone, at high standard dose is used as antabuse and is an opioid receptor antagonist, but actually at really low doses, or what's called LDN, and this is something that can be prescribed easily prescribed from a compounding pharmacy and be very inexpensive. It's, again, the opioid growth factor antagonism, but also works at toll-like receptor 4 antagonism and has been used before in some ME/CFS, fibromyalgia, Crohn's disease, multiple other places. Well, it helps kind of control the immune system and be a little anti-inflammatory for these patients and help decrease pain and fatigue in these other disease states, including MS. And so there's a study now of low dose naltrexone in PASC, and it's showing also helping in multiple symptoms: chest pain, tightness, cough, joint pains, mood, personality changes. So again, something that can be, is very, very safe, can be started on your patients who are having these ongoing symptoms. Some of the thoughts is their mitochondrial dysfunction. There's going to probably be a trial on the AXA 1125, which has to do with mitochondria or other mitochondrial directed therapies. We talked about microvascular disease, and I know there might have been some questions on anticoagulants, thrombolytics, some of the persistent microclots studies that are being done outside of the US look at some of the anticoagulants also as well. And then endothelial dysfunction, because this is a vascular type disease that it can impact lots of places of the body. And EECP, or enhanced external counterpulsation, is something that was previously used for refractory angina. And now we're using it in long COVID to help with since it's endothelial dysfunction type disease. And this is something where they get compression, almost like cuffs on their legs, and then they get a 3-lead EKG, and every time their heart goes into diastole, it squeezes in a certain sequence. And this, it helps with diastolic augmentation and increases shear stress. And part of that increasing the shear stress is helping to increase growth factors and increase nitrous oxide. So it's going to help with ischemia, vascular tone, creating new vascularity, cardiac efficiency, and it's been helpful in our patients with long COVID. This is in the first 50 patients that they had seen with their fatigue scores, chest pain scores, quality of life scores, and 6-minute walk tests. We've also looked at doing cognitive tests, and it helps patients with some of their brain fog as well. So, there's more. They're not related to UT, but there's centers called Flow Therapy that are around town and in Austin as well. So again, work together in the community with, getting the right types of rehabilitation and other supports for patients, and kind of left you with the last little message that I like to tell people: would good enough be good enough for you? If this was you who were dealing with it, or your family member, are you going to try to kind of figure out and see how you can help them? And don't be afraid of giving them the diagnosis.
Lots of information there. Thank you so much, Dr. Verduzco-Gutierrez, for sharing your expertise with us. I'm sure there are a whole lot of questions. I'm going to start with something that I'm sure is pretty easy for everybody to look up, but I'm hearing that some doctors in the community aren't aware of what the ICD-10 code is for long COVID. And I've had some people tell me that their patients who aren't getting reimbursed for these visits for long COVID because people aren't using the right ICD-10 code. Can we start with that simple question?
Yes, it's U09.9, and it's pretty, that's kind of long COVID generic code that can be used, and then patients can get things covered for it. And then you can look it up, and if you have Epic, then it's you can look up PASC or long hauler or long COVID, and it will usually come up.
Okay, thank you very much. Now, going to the chat, we're going to spend a few minutes on Q&A from the chat, and then we will go to cases, and we have 2 cases today. Marshall Packard is asking, is there any way we could get a PDF of this presentation?
Sure, yeah.
All right, so perhaps we do, for everyone's benefit, we post the entire recording on our website, and you can view it afterwards. You can share it with your friends, so all of that's there. But in addition, we will work with Dr. Verduzco-Gutierrez to get the PDF and send it out to people who are on this call. So thank you so much for that. Dr. Ratna Sanka, who is our neurologist on the panel, has put a helpful link in the chat. Dr. Sanka, what is that link that you've put in the chat for us? It showed up about 10 minutes ago.
It is a link from the AAPMRR group, the Association for Physical Medicine and Rehab, that has all the existing guidelines that we have and all of us have put together to help everybody take care of patients with long COVID. And there are guidelines for fatigue, there are guidelines for breathing difficulties, cognitive difficulties, autonomic dysfunction, pediatrics, and there are more coming. So if you have that link to that website, you can go check in there periodically because there are new guidelines that are coming.
Thank you so much for that. I'm going to keep watching the chat. So people, please put your questions in there. And while I'm waiting for that to happen, I have a follow-up question about EECP. You kindly showed us what that stands for, Enhanced External Counterpulsation, and it's sometimes referred to as flow therapy. And I have heard of this being used for people with dysautonomia in the setting of long COVID. Something that has puzzled me, and maybe you can help us, Dr. Gutierrez, is how if people are going intermittently for this treatment, where in diastole they get a counterpulsation, right, with the inflatable compression that's on their limbs. How is it helping them beyond the time when they're in the cardiologist's office getting the EECP? How is there a lasting effect, and how frequently do they have to go for these treatments?
So usually they're going an hour a day for over 35 days. And so it's over, the effective time. So it's changing biomarkers in the body. It's shown to be decreasing inflammation. And so that's why it helps for then a period of time afterwards. And we know there's a lot of data in angina before. And so it's been helpful in these patients that also have angina for several years afterwards.
All right, thank you for clarifying that. I see a question from Dr. Liam Du of University Health System. Out of 1,000 patients who had COVID, how many would have one of these long haul symptoms?
So they're saying 1 out of 5 people at this point. And this is even with, and they don't all have to be very severe ones. Some people are just living with, believe it or not, I can't exercise like I used to. I can't work out as hard as I used to. I had a friend that could run a 33-minute 10K. It's like 6 miles in 33 minutes. And then he's dealing with long haul COVID and can't even run right now. But otherwise, every other system of his body is fine, and then some people, it's just a little fatigue. Some it's an autonomic dysfunction. So they're saying 1 out of 5 is what's coming out of the CDC and from the Household Pulse survey as well.
Well, this is pretty extraordinary and suggests, vast numbers of people being affected. Are there data coming out now telling us whether getting vaccinated actually helps prevent long COVID? We know that we can be vaccinated and boosted and still get symptomatic and sick from COVID with the new variants. But does the fact of our being vaccinated, does it extend some protection against long COVID, or do we have that data yet?
There is that data, and it's some protection, but it doesn't completely protect you from it. So some people who are still even vaccinated and boosted still are at risk of getting long COVID, though it's less.
Okay. Dr. Cesar Garcia asks, how often do you see GI symptoms in kids? And then what types of symptoms?
Yeah, so I would probably say the GI symptoms, well, I don't see kids, but I follow the literature very closely and presented with a lot of the long COVID kids specialists. And it's probably in the top 3 or 4 symptoms that kids have is GI symptoms. And it's going to be, their stomach pains or bowel changes is kind of probably the most common GI symptoms that there are in kids for sure.
And I think you referenced that this might be related to mast cell dysfunction. Would that be kind of a scenario where you'd be trying the H1 and H2 blockers and the Singapore?
It can be, yes.
Okay. I don't see any more questions in the chat right now, but let's move to our first case. And we do have Dr. Shi, Dr. Yun Shi from Family Medicine, who can present her case to us. Go ahead.
All right, this case I'm going to present is 50-something-year-old male presented to our clinic several times since last year. And he has this chief complaint of chronic fatigue. And he also reports this symptom kind of correlated with he getting infected with COVID in January this year. So symptom persisted over the last 9 months at this point. And on top of that, he has multiple comorbidities, including HIV, hypertension, sleep apnea, which is untreated, waiting for his BiPAP CPAP machine to be ordered and approved, NAFLD, obesity, hyperlipidemia, prediabetes, carpal tunnel syndrome, allergic rhinitis, and some mental health concerns as well, depression and anxiety. And he, like I said, he has the COVID back in January, and it's unclear whether he had that symptom or not. This was tested outside of our system. This is based on patient's history, and he has been fully vaccinated as the Pfizer vaccine, as I documented there, and no allergies. So taking a lot of medications, and on top, what I can remember, statins for cholesterol issues, beta blockers, calcium channel blockers for the hypertension is still getting worked up for better control. He's also seeing the HIV infectious disease specialist under treatment for his HIV. I think in later on can show that his viral load is relatively low at this point. And he's also, there are 2 more blood pressure medication. I kind of skipped hydrochlorothiazide and lisinopril, and some allergy medication, trazodone for sleep. So socially significant, he has been a former smoker, but no longer smoking. Ethnic group is Hispanic, and some positive family history there, cancer, diabetes, hypertension, heart disease. So his review system, the positives are increased fatigue, has some shortness of breath after exertion, also endorses anxious mood as myalgia, poor sleep, which has been known for the last 2 years also. So the sleep issue is persistent, chronic, unrelated as far as timeline goes with the onset of increased fatigue. So pertinent negatives are no fever, chills, constipation, weight loss, weight changes, edema, hyperglycemic type of a symptom, no rashes or skin changes, no cough, dizziness, weakness, lightheadedness, and no suicidal ideation. So from our limited exam is that he's obese with BMI of 40, which I didn't include here, but has the uncontrolled blood pressure still elevated with 4 medications on board at this point. The pertinent labs are, we've done CBC, TSH was the first thing we have tried to make sure there's no thyroid issue. Chemistry mostly normal with I think the sodium was slightly low. Otherwise, labs are within normal limits. The CD4 is 800 at this point. So we, several different providers before me, I've only seen him one time. So before us has tried to make sure there's no endocrine issues, and his OSA, we know is uncontrolled. We were trying to get his CPAP, BiPAP ordered and getting started to use. So at this point, we are considering COVID could be a contributor to his symptom, but with all the comorbidities going on, how can we confidently say this is part of the post-COVID syndrome or PASC? Like Dr. Gutierrez has said, don't be afraid to call it, but I'm a little concerned, trying to make sure we're not missing anything, but we do wanted to also aggressively manage all his other comorbidities. That's my first question. The second question is, before this patient getting seen by a specialist, does he need to be referred to a specialist, or can we just manage him in our outpatient PCP clinic? When do we refer? Thank you.
Wow, complex case, and yet not such an extraordinarily unusual patient, right? I mean, this is basically a person with obesity and metabolic syndrome. He happens to have HIV, which seems to be well controlled, but now he's got additional problems that seem to have followed or been compounded after an episode of COVID. So how do we sort him out, and which category would he fall into? That first slide you showed us, Dr. Gutierrez, dividing in the people who have an obvious complication of COVID versus those who have something that's autoimmune and inflammatory and ongoing. How would you approach it?
So I would approach it as, I mean, I think you're thinking in the right way and thinking about, all right, are we ruling everything out that we're supposed to in someone who has fatigue? The way I see COVID is for patients, it's basically igniter fluid. So anything that they kind of had before, it's just going to put, just open the flame on. So if it was like a little fatigue, a little sleep deficits, well, now that there's all these interleukins, interferons, all these, you've kind of switched your spleen to make more inflammatory types of cytokines, then patients, they're going to feel bad and they're going to feel, worse with what they have. The thing with the viral reactivations, just want to make sure that you would, rechecking their I think it had said like 7 months ago, but was that when around COVID, or has it been checked since he's had COVID in regards to his HIV, just because that can, also be reactivated as well, or become a little bit worse with just following what his viral load is for that. But I think you're doing the right thing in wanting to, I know it's hard to find CPAPs right now. They're on back order and supply chain issues, but trying to get him to sleep, and then also screening for the post-exertional malaise. So are you fatigued? And is it worse when you work? This is someone that you had said worked. So do we need to cut down what he's doing a little bit more to be able to, control what his symptoms and what his fatigue is? And if he's having arthralgias and myalgias, do you want to screen? I know all the rheumatologists are gonna send me hate mail, but do you want to look for an ANA? Do you want to look for, something rheumatologic going on, just to say, okay, it's not that, and move on?
Thank you. As an HIV doc, I'll just add to the point about the checking the viral load. It's true that some other virus, anything that revs up the inflammatory cytokine profile of an HIV patient, can cause a blip in their viremia. So previously undetectable, HIV undetectable patient might have detectable virus because of inflammation. And that doesn't necessarily mean that there's anything wrong with their antiviral regimen, their HIV antiviral regimen, but it is helpful to know, and something that should be watched, because if the viremia, the HIV viremia, persists or is increasing, then there's a risk of the development of resistance, and that should be screened for. Dr. Shi, did you have follow-up questions or points to clarify?
So somewhat unrelated to this case, I was just wondering, what is the prognosis for patients with long COVID, and even with the optimal treatment based on the evidence we have?
Can I just add to that, Dr. Shi, as from talking to a number of other providers, we had a lot of cases that got submitted for this session. We won't get to all of them, but people are casting about for how do we give folks anticipatory guidance. Patients want to know, how long am I going to be dealing with this? And is there anything out there that we can point to that to know what to expect?
Sorry, repeat.
So what resources do we have that can help us provide anticipatory guidance to patients that are suffering from long COVID about how long they should expect to be dealing with these symptoms?
Yeah, you have to, we don't have good data on even counting the number of people with long COVID. So it's even harder to get data to say what happens. But there is data that's showing some patients, when they have symptoms at 2 months or 3 months, that multiple are still having symptoms at a year or 2 years when you look at the majority are. But it's about symptom management and controlling it. So a lot of times, are they starting to feel somewhat better and be able to get it controlled if you can do these different things for them? Okay, if they're able, I can put them in float therapy, and I can, make sure that they're sleeping well and give them medications for that, and at least control things where they know how to control their, their energy window and know what to do with, to be able to have a little balance with their life.
Step by step, it sounds like. I would like to go to our specialists with this same question. So Dr. Pillarossetti, a cardiologist, has joined us. Dr. Pillarossetti, we see patients that have dysautonomia, labile blood pressure, and things like that. And some of them are seeking the help of cardiologists, and some of them are getting this flow therapy, this counterpulsation therapy. How would you provide anticipatory guidance to a patient that has that set of long COVID-related symptoms? How long should they be expecting this to go on? Is there hope? Does it resolve?
I can tell you from my experience, certainly there is there's a little bit of data out there. And we, in fact, looked at our set of patients, those who have been to the cardiology clinic and have been undergoing rehab. We looked at their prognosis at 6 months, and a lot of them still continue to have continued symptoms at 6 months, but most of them did feel better. I mean, the symptoms were still there, but they have now been able to manage their lives, and all of them have attested to physical therapy and rehab being the most, the one that has helped them in their management the most. I always counsel them on, again, most of these patients have tachycardia or they have orthostatic hypotension. And so I always counsel them on the importance of taking large amounts of fluids, about 2 to 3 liters, which is more than 64 ounces of fluid, and also being liberal with salt intake. And they are usually surprised, and they would say, well, we are not supposed to take in salt. And I say, well, this is the only condition where, you will have to take, be liberal in the amount of salt that you take. So some people have had improvements just with some lifestyle changes, but a lot of them do require physical therapy. Some people have noted improvements over a course of maybe 6 months to a year. But again, at the end of the day, they all have the symptoms, although the intensity may have, come down.
So a theme is be patient, I would say. All right, we have lots of cases, and I'm seeing a text from Dr. Miguel Palacios, who would like to present his case. So I'm going to ask Dr. Avery to hold on, and we'll go to Dr. Palacios. And Kato, are you able to bring up the Dr. Palacios case? And Dr. Palacios, are you still with us? There you
Yes,
are.
I'm here.
Okay. All right, maybe you can go ahead and start presenting, and if Kato can catch up with the case
Sure.
form.
I'll make mine brief. So this is a 47-year-old Latino male. He has a history of poorly controlled type 2 diabetes, who had presented to the ER for shortness of breath. His symptoms had started 7 days earlier. I'm actually his PCP and have known him for several years. And I was able to take care of, also take care of him in the hospital during his admission once he was downgraded from the MICU. But his main risk factor was that he had very poorly controlled diabetes, and that's because he admits to diet and medication non-adherence. His A1C at the time of hospitalization was 9.5. He had a very prolonged hospital course. So he was admitted July 7th and wasn't discharged until August 14th. This was in 2020. He required intubation and then tracheostomy. And then after he was discharged, he was able to be decannulated in September of 2020. During his hospitalization, he also developed a left deep femoral vein DVT, and then subsequently completed 3 months of anticoagulation with apixaban. After discharge, I saw him. He was struggling with a lot of diffuse fatigue, muscle weakness, dyspnea. We were able to get him into the PM&R long COVID clinic, but unfortunately he was only able to be seen once and didn't follow up with them. And then in August 10th of 2021, so 13 months after his hospitalization, he presented to my office with acute left calf pain, and we diagnosed him with an acute DVT, again of the left femoral vein, and he was restarted on apixaban. Eventually, we got him plugged in with hematology, and a coag workup was pretty much negative. He ended up taking apixaban for an additional 12 months and stopped it September of 2022 after shared decision-making with the patient. Overall, his functional status has slowly improved. He started working again, but now doing more administrative type tasks. So my questions are, typically how long does the hypercoagulability associated with COVID-19 last? And kind of what are the current recommendations regarding anticoagulation in a post-COVID or long COVID type picture?
Okay, let's take them one at a time, and because if you give us all three, we'll all forget what the first one was. In our pre-rounding session, Dr. Ratna Sanka, who is a neurologist, actually kindly looked up for us some COVID-19 management guidelines, and I believe that within that, there are some standard guidelines regarding the duration of anticoagulation. May I please call on Dr. Sanka? Would you unmute and draw people's attention to the guideline that you found?
Yes, and I'm going to be out there. This is not an area that I specialize. I was trying to look up some guidelines, and I think American Society of Hematology has some guidelines and I will paste it in the chat. But most of them do talk about inpatient during hospitalization guidelines, and if you have a DVT, which is to continue it just like he had in this, but again, it is still early. I have not found any guidelines on long-term need of anticoagulation. It looks like whatever this patient received was appropriate for those guidelines. And again, this just highlights the fact that there's a lot of things that is still unknown in the post-acute COVID and the long COVID syndrome, and we just need to be hyper vigilant of their symptoms and do the appropriate management. I'm just going to try to post the guidelines link that I found in just a few minutes.
All right, thank you. And for your second question, I see it there, Dr. Palacios. We kind of touched on it a little bit earlier. These data are continuing to accrue, but certainly we encourage people to get vaccinated to prevent COVID infection, to prevent a severe COVID infection. And hopefully this can help prevent the long COVID symptoms, but these, we need more information. We need to follow people for longer to answer that kind of question with data. And your third question, you want to tell us about that one?
Sure. So for like this patient who had limited resources regarding, finances, time, etc., I guess as a PCP, for an individual like this, what is the best thing we can have our patient do to try to help mitigate some of these symptoms of long COVID?
All right. Dr. Monica, would you like to help us with that one?
Yeah, I think it kind of just depends on what their main symptom is. But I think, one of the main things I've been trying to stress is pacing themselves. So, really figuring out what is causing crashes they might have and having them not doing that, and really, pacing themselves. If they can get the flow therapy, I think it's worth doing if they have that kind of time or resource. And then it just really depends on what's, their other main symptom.
Thank you. I'm going to also ask Dr. Ratna Sanka. So let's say a patient is someone who would like to see neurology for their brain fog, but they can't really get in because there's a long wait time. What should they be doing in the meantime?
I think we do recommend kind of evaluation to see if there are any comorbid conditions that are exacerbating the brain fog, and some of them were kind of we talked about it in the previous case, which is sleep, which is a very important risk factor for exacerbating brain fog. So appropriately making sure they get enough sleep and good quality sleep. If they have untreated sleep apnea or if they have insomnia, we need to make sure the sleep is addressed. The other factor that we are seeing in the brain fog is medications, and some of it. Some of the medications they're on or we are recommending, which includes antihistamines for possible mast cell, can exacerbate the cognitive dysfunction. And sometimes we put them on beta blockers for tachycardia that can exacerbate cognitive dysfunction. So I think it's a balancing act that we are trying to do, trying to control their symptoms and also preventing the side effects. Endocrine dysfunction, I know thyroid is one thing, but we are seeing some adrenal dysfunction. So that would be something to add on to the evaluations. And a lot of times fatigue could be also, if there is a postural fatigue, I just want to throw in some, just a few words that if they say that I am more fatigued when I'm upright and doing exercises, just look for autonomic dysfunction. Are they orthostatic? Are they tachycardic with just standing up? And that's where the fatigue is also triggering. And if all of them have been ruled out, just reach out to us. There may be more, like we may need to do cognitive testing to see if these patients had some underlying mild cognitive dysfunction or some other illness that is causing this, and we're just blaming it on the COVID. So we still have to make sure we're ruling out all other causes and before we completely say that this is from the long COVID.
So Dr. Verduzco-Gutierrez told me that there's a 6-month wait or longer to get into her post-acute COVID clinic. How long does it take to get into your clinic, Dr. Sanko?
Dr. Gutierrez is laughing, about the same or even sometimes worse. But I just want to say we are available to talk to help see if there's something that we can add to the evaluation before you come in and see us, or we are available to figure out a way to get them in for further testing if all of them have been done. So definitely please reach out to us. And sorry, I'm not moving enough, I think. So.
All right, we heard some good suggestions though about what primary care doctors can do along with their patients, making sure that they have good sleep, reducing unnecessary polypharmacy, getting rid of drugs that could make them sleepy, working up for endocrine dysfunction, and evaluating whether there are postural symptoms to see if they have dysautonomia. All right, I'm seeing Dr. Romero nodding at me. Dr. Romero, my co-moderator, should we go to some quick questions from Dr. Rochelle Avery's case? Do we have 1 minute?
We have 4 more minutes. Yeah, we can do that.
Okay, Dr. Avery, thank you for being patient with us. And if you could just really give us a brief version of your case and get to the questions, we want to address those too.
Okay, so I'm going to be 2 minutes. So this is a 67-year-old female with a lot of comorbidities. Significantly, she has diabetes and also follicular lymphoma, grade 3A, and on chemotherapy. So what this patient tested positive for COVID on the 7th of July and was treated with Paxlovid. 1 month later, she was still having symptoms and tested positive again. This patient then worsened, and her symptoms included shortness of breath, fever, then diarrhea, abdominal pain. She was actually admitted in August 7th and was diagnosed with acute hypoxic respiratory failure and was treated for pneumonia, also had C. diff, also had E. coli, pyelonephritis. She received remdesivir. Eventually, she was discharged, but continued to have symptoms. She is currently off of her chemo since July, and she's still off of her treatment from the oncologist at this time. My question is, for this patient on chemo, what is the best initial treatment that we can give to them? And secondly, would she be a candidate for Evusheld?
So this is a very complex case of an immunocompromised host who was actually treated not once, but twice, once with Paxlovid and once with remdesivir, and that we have at least 2 time points separated by 1 month where there was evidence of positive virus. So we do read in the infectious disease literature, of course, about patients who are seriously immunocompromised who seem to harbor this virus for a much longer period of time. And there are hypotheses that it's just such patients, in fact, that may be helping to generate the variants that we are seeing. And of course, we worry that these are the types of patients who, once we expose them to antivirals, may also be helping to foster the generation of drug-resistant variants, which we haven't seen too much of so far. Does one of our panelists want to address any issues related to whether the first choice of therapy is going to impact an outcome for a patient like this? I'm not sure that there is data like that. You can unmute if you want. Getting Paxlovid for a person who is not meeting inpatient criteria is very appropriate. And of course, in this patient who's medically complex, there will be many other medications on board. And this would be a patient where you would want to consult with a PharmD and or use the online resource from Liverpool, UK, where you can type in the names of your patient's medications, the generic names of your patient's meds, and find out if there are any contraindications to using Paxlovid. And if you don't find any, then and the patient is outpatient, then Paxlovid is still very appropriate. Your alternatives would be molnupiravir, not as effective as Paxlovid, but an oral outpatient medication, or IV remdesivir. And IV remdesivir can actually be given in the outpatient setting. It requires finding an infusion center that will have this drug available. So you don't necessarily have to be an inpatient to get remdesivir like you did a year or two ago. So that would be the first part of your question. And going back to your other questions, Dr. Avery?
Oh, yes, thank you for that. The second question is, would she be a candidate for Evusheld?
Right, so I'm going to grab that one also as an infectious disease doctor and talk a little bit about what is Evusheld and who gets it. Evusheld is a combination of monoclonal antibodies that are given by injection as opposed to by infusion. And this is something that is given upfront to prevent infection and not as a treatment. But patients who have a cancer such as lymphoma, blood cancer, and who are on chemotherapy, those are people that are in that category of severely immunocompromised host. Others would be solid organ transplant recipients. These individuals are not likely to mount a good immune response to vaccination, so we can give them Evusheld to prevent infection, and the Evusheld duration of efficacy is about 6 months. So because the pandemic persists, you would have to give them the Evusheld. Evusheld can be given at the Mays Cancer Center. There are many other venues in town where this can be found. We have a mechanism to order it in our electronic system, and it typically goes to a doctor in hem-onc who will review the indications for the Evusheld and make the final approval. So once again, to clarify for our audience, Evusheld is a combination of monoclonal antibodies given by injection to prevent COVID-19 in severely immunocompromised hosts, but it does not have a role in treatment of COVID-19. Dr. Romero, back to you.
Thank you very much, Dr. Bergen, and thank you so much. We just come to the end of our session. Thank you so much for your participation. Excellent cases, excellent discussion, Dr. Avery and Dr. Shi. Thank you so much, and also Dr. Palacios for presenting the case. And we invite you to present cases. Please consider present a case in our future sessions, or present a follow-up from cases that has been presented. We would like to hear from you and your experience. Thank you very much, Dr. Monica Verduzco-Gutierrez, for the didactics, very, very informative. And the link for the PDF and the recordings of our session are gonna be in our chat, and I think I saw at 12:30 that was the link put in there. Well, thank you so much, you all, for being our sessions. Please mark your calendar for next session. Is gonna be in 2 weeks. It's gonna be Friday, November 11 at the same time. Thank you very much, and you have the wonderful rest of the day. Thank you for joining our session. Thank you very much.